A stronger day, be your best every day. Hi, I'm Adimus, founder and director of Strength Optimizer. I aim to help you stay healthy, be happier, and deal with challenges with greater resilience. What was your first impressions when I mentioned the word psychiatry? Have you heard about cognitive behavior therapy or CBT? And how do you drive a change to create a world where mental illness is seen as in the same light as every other illness? Today, you will meet Professor Farooq Naeem from Canada. Farooq will share how CBT can help to promote mental health well-being in a diverse culture. Thank you. Hi, I'm Adimus, founder and director of Strength Optimizer. Thank you for watching Strength Optimizer, the Science Up Your Wellbeing series. Today, we have Dr. Farooq Naeem joining us from Toronto, Canada. Farooq is a psychiatrist at the Center for Addictions and Mental Health and a professor of psychiatry at the University of Toronto. He is considered a leader in global mental health. He's also a cognitive behavior therapist, which he has pioneered techniques for culturally adapting CBT for the varieties of common and severe mental health problems in South Asia, North Africa, the Middle East, and China. He works with a team of IT experts to develop a CBT-based therapy program called eGuru that can be delivered through web and smartphone apps. I'm so grateful to have you today, Farooq. How are you doing?
I'm fine, thank you. And thank you so much. Privileged to be with you. Thank you.
No worries. Once again, thank you for taking the time to share your insights into mental health and cognitive behavior therapy, or CBT, particularly how CBT can help to promote mental health well-being in a diverse culture. So, Farooq, you are a psychiatrist and a leader in global mental health. What are some of the misconceptions about psychiatry?
Well, there are many misconceptions. So, if we, uh, uh, and if you especially, it depends where you are. That depends where you are as well, right? So, there are the misconceptions in global South, and then there are misconceptions in global North. So, for example, many people in global South, including the low middle income countries. I think a lot of people I realized through my work, first of all, it's not really even misperception or misconception. I think it's a lack of awareness. That's the first thing. So before, because you see, you need to have some knowledge or awareness to have misperception. But the problem is there are so many people who don't even know about psychiatry. People don't know about the psychiatric disorders because they use a very different kind of model of mental illness, which is grounded heavily in spirituality and religion, right? And that means many people have no information, they have no knowledge, they have no awareness of psychiatric problems as we know in the West, or as we know even in the East, using, or other parts of the world, using the modern psychiatric classification. So I think that's the biggest kind of issue. So that's the problem, is even before the misperception is the lack of awareness. And that obviously leads to several problems. So, for example, people present only to faith healers and religious leaders, and then obviously when there are not many people who recognize they have a problem, I think that has a huge impact on the health systems, Animus, because health systems change because of the pressure from patients, pressure from people. So if people don't know they have mental health problems, they can't do any kind of advocacy work for their own rights.
All right, that's good. So it's the issue, as you mentioned earlier, is more about the lack of awareness or the lack of understanding, and with that, it also means that people may not necessarily will be actively seeking for psychiatric treatment if they don't know that there's such services available or don't know what's all about. And sounds like, as you said, in some of the cultures that psychiatrists sort of kind of, or mental illnesses intertwine with religious and spiritual beliefs.
That's right. That's right. Yeah.
Okay. Yeah. What about within? I guess that if I may use the word like the developed countries, have you also experienced any of the either it's lack of awareness, understanding, or some sort of misconceptions when it comes to seeing a psychiatrist?
In the West.
Yes, that's right.
Yeah, well, I mean, in the West, yes, while people have more knowledge of psychiatric problems, but there's still a lot, there are a lot of issues. So, for example, many people wouldn't know the difference between a psychiatrist and a psychologist, right? So, that's a common kind of thing. And but then there are many things, for example, people quite often they expect you to prescribe medication only in psychiatry. I mean, mind you, that's possibly very similar in global South. So, for example, in our work, we found that people with depression, for example, and anxiety, those who have somatic symptoms in developing countries, they go to see a family doctor or gastroenterologist or neurologist, and those who have the psychological symptoms of anxiety and depression, they go to faith healers. So, so this kind of divide does occur, but in the West, or in global North, as we say, yes. So the problems are possibly not. They are on a different kind of level, a different scale. So yeah, as I said, first thing is, people expect you to be only prescribing medication in psychiatry, and then then there are some other funny ones. Look, for example, if you meet someone in a meeting and you say you're a psychiatrist, the first thing they say, "Can you read my mind?"
Yeah.
So,
the classic. Yes, you read my mind.
That's a classic one. Yeah.
Yeah. Okay. All right. I guess that I know later on we're going to talk a little bit more in terms of the stigma around mental illness, but I guess that as a psychiatrist, especially for people who are not necessarily familiar with the process, maybe you can briefly help us to unpack or understand like when someone comes to see you as a psychiatrist, what is generally what happened during the first session, the initial process.
So I do work in I work with one assertive community treatment team, and then where we have mostly patients with schizophrenia. But then in my general outpatient clinic, which might be more relevant to your question, generally we see mostly patients for consultation, second opinion, and they come for, mainly referred by the family doctors.
Okay.
So yeah.
So it's a referral from family doctor, and then from there a second opinion for further
That's
consultation
right.
or
Yeah.
assessment. Yeah.
And sometimes from the other psychiatrists too.
Okay. Okay. Excellent. Excellent. All right. We know that the COVID pandemic has generated unprecedented attention and concerns on topics like mental health, mental illness, resilience, flourishing, or thriving. What are some of the differences and similarity between all these so-called constructs?
So yeah, first of all, COVID and mental health. I think one thing we need to keep in mind is that people experience mental health problems once they have gone through the traumatic experience, right? So, for example, it won't be in the middle of an earthquake that people experience mental health problems. It's when that acute emergency phase is gone, where life is threatened. So, in other words, while understandably we are seeing higher rates of mental health problems these days, but I think, and I hope that I'm wrong, but the problems, we'll see the actual problems once we are in better control of COVID. So that's the time when we'll see more mental health problems.
All right.
Now, in terms of resilience, Obviously, resilience now, so is a poorly researched topic. Interestingly, although I think it came to surface again during these times of COVID, people started talking about resilience again, and uh, so resilience is your ability to bounce back.
Okay.
In other words, resilience is not the kind of it's not something that we can check all the time, because you will see resilience in someone only when they're going through a tough time, right?
Yeah.
So you will not see resilience when everything is going kind of smoothly.
Yeah.
So that's the kind of basic concept of resilience, your ability to cope with problems, with difficulties, and not only cope. I think people often think resilience is just really about recovering from adversity. Actually, resilience is also about learning from that experience, and so you can use it in the future. Those skills that you have learned while coping with a certain problem.
Yeah, yeah. So it's interesting when you say that resilience is almost something that is dormant, that this kind of is there but has not been activated. And in today's, especially in the West, when there's a lot of emphasis on resilience, and a lot of people are saying that tell me to build resilience skills. It's almost saying that if you want to really grow in resilience, that means that you have to be going through some sort of challenges and hardships. But the things that we in general humans, we do not like, or at least we do not actively seek pain or hardships. It's almost like a paradox. On one hand, we say that help me to grow my resilience, but on the other hand, people are saying that, but I don't like to be in difficult or pain or in suffering or hardship situations. So therefore, it
Sorry,
sounds like
you cut off the last thing you said.
or was just saying that I know, as I say, on one hand, nowadays a lot of people want to grow in their resilience, but on the other hand, in general, people do not want to go through hardships or challenges. But what you're
Okay,
saying that in order to grow in resilience, we got to go through the hardships or challenges.
that's very true. That's very true. I give you an example. So when I talk to people about resilience and CBT,
Yeah.
I quite often give them some useful tips. So, for example, one thing I say to them is to try small changes in your life. For example, once or twice a week, I try not to. I am very dependent on my GPS systems.
Yeah.
In my car, there's one on my mobile phone and all those kind of things, even when I'm going to work and back. And once a week, I try not to use that system and take a different route, just to kind of have some change, and uh, uh, so I think change is a very important thing. If you want to become resilient, you'll have to accept change. You'll have to learn to cope with change. And it's not just the simple kind of change or stressful things. One other issue that I noticed that people don't think about is the boredom. That's another area which I think people don't know what to do when they're bored. Uh, and in this day and age, you'll see everyone on the mobile phone, because if anything, people are scared of boredom.
Yeah.
That's another
Especially
area.
yeah, especially right now here in Melbourne, we are going through our sixth complete lockdown, whereas a lot of the activities has been limited, a lot of restrictions, and you're absolutely right. Whether it's adults or whether the kids, borders seem to be a major challenge right now.
Mm-hmm.
Right.
No, I can totally see that.
All right. So what about the whole concept of thriving or flourishing, especially stem up from the movement of applied positive psychology? Again, what are the differences compared to resilience?
So one concept that's very closely linked with the resilience is self-efficacy.
All right. Okay.
Right. And self-efficacy does not get the attention, as much attention as it should. And the reason I say that is there's plenty of evidence from research that shows that if you help people become self-efficacious, if you increase their levels of self-efficacy, they are more likely to be resilient.
Okay.
Right. Now, interestingly, self-efficacy is something that's more kind of that's measurable, and it's more like an active state. Self-efficacy is your belief in yourself that I can do it. I can overcome this problem. I can go through this this difficult time. So that belief, that's the main kind of that's the core of resilience. And self-efficacy can be developed. You can learn to become efficacious. You can become more. You can have higher levels of self-efficacy, and it can be done through the CBT technique. So, for example, one part of self-efficacy is cognitive flexibility. So, cognitive flexibility means, are you able to see more than one aspect of an event? Right? Because people who don't have cognitive flexibility, they're usually stuck on only one concept. In CBT, the whole purpose is to help people to be able to look at things from more than one perspective. And the whole kind of idea behind the food diaries is that you help people to become to become more sort of flexible, in that they can see that this is one type of thinking that I have, but when they create a balanced food or alternative food, you're teaching them to be cognitively flexible, right? The other things which help become or increase self-efficacy are having a meaning and purpose in life. Having a motivation, a source of motivation is very, very important. So, for example, if you're going through hard times, that you have a family to feed, for example, and the purpose doesn't need to be really, a grand purpose. The purpose can be very small. Like, I love my family, so that's why when there's a difficult time, I should survive and I should work hard to come out of these difficult times, because I have a family, I have kid, I have wife, and I love them, and therefore, that keeps me alive. That gives me the energy, gives me that force. Okay. And then there are other things which are also part of self-efficacy. For example, your ability to solve problems, that you can learn easily from problem solving. Okay. Then there are coping skills. Now, we know generally, in general, people who are better able to deal with day-to-day kind of problems have better and healthier coping skills. So these are some of the kind of concepts that are linked with resilience, and I think it's very important to have more research, to be honest with you, on these areas.
That's great. That's great. So it's almost saying that by teaching people, helping people to build the skills of self-efficacy, then it can have a direct positive impact benefits when it comes to building resilience. Self-efficacy may be a big word for some people, unfamiliar word for some people. And on the surface, when you talk about self-efficacy, it's having the belief that we had ability to do something. And sometimes people may quickly associate with positive thinking. Wake up every day, look at myself in the mirror and say that today I can do this. Is that self-efficacy? Means that positive thing?
So, I mean, I'll be very honest. I'm not an expert on positive psychology, and I have, read a little bit, but that's not my area of expertise or an area that I have studied extensively. Uh, uh, but I think, broadly speaking, that is what it sounds to be. So having that uh, uh, but then my understanding also is positive psychology is mostly looking at the positive side of something, and that's very broad. And you have to forgive me for my ignorance. Uh, uh, Self-efficacy is more really a your and obviously when you say the way you look at it, or when you say something like you wake up in the morning and you say, okay, I'm going to do it today, uh, and all those kind of things. But you see, that comes from your belief system, doesn't it? The thought that you have, and in CBT theory, we have a kind of very simple sort of example. Or analogy, sorry. So you think about the belief system as the roots of a tree. Okay, and the and uh, and your thoughts are like the leaves of the tree. You see, your thoughts come from your belief system. So the thought in the morning that I can do it is obviously that's coming from your belief, and your belief is that, okay, I can do it. I can uh, uh, and so for example, on a very simple scale, it will be, if I have to appear in an exam that you have passed before me, I'll have my self-efficacy will tell me, if Adamus can do it, then I can do it.
Okay. Yeah.
It's that belief, that's that belief really, and then obviously, as the level goes up, then the strength of the belief becomes stronger, and then there'll be a stage when I'll say, okay, even if Adamus didn't do it, I'll do it. Right? You see the levels.
Yeah. And I guess that I might also qualify that while, correct me if I'm wrong, while the belief is important, you also need to back up by a certain level of motivation and skills. Otherwise, having the belief to say that, yes, I can do it, but without having the skills to execute or the motivation to sustain, then perhaps after having this so-called motivation belief in our head, but realize that actually there's a gap between of what I can do and what I believe I can do, can, I guess, that put people in perhaps a depressive state, saying that eventually actually I can't, I thought I can do it, but actually I don't have the skills to do it.
Yeah. So that's where there are two things. One is your theory of belief formation. Where do the beliefs come from, right? Our beliefs come from our childhood experiences, our what we see on TV or hear on the radio, or hear from our parents, or see things around us. So, for example, it is understandable that during the last year and a half, the most common belief that people shared possibly was the world is a dangerous place, right?
Yeah.
So that's where the beliefs come from. And the second thing is, also we then maintain our beliefs through two kind of internal processes. We actually focus on information that uh, strengthens our beliefs, and we ignore the information that's against our belief system. Right? So that's how the beliefs are formed and maintained. And what you're saying is a very important thing. So what happens, and obviously our beliefs are constantly, not all beliefs, obviously, but some beliefs are constantly under attack. So, for example, you might believe that you can pass this exam. However, you might not have the ability. You might not have the strength to go through a certain difficulty, and that's very right. However, it will actually, if you survive the difficulty, obviously, then you will be able to revise or review your belief system and say, all right, okay, I should not do this thing again, maybe next time or something like that. So that's really one aspect, and the other is, uh, the positive aspect, and that is like, when you have passed like 5, 6 exams in your life, or have passed 20 challenges in your life, that also gives you, that also strengthens your belief,
Yeah.
right?
Yeah.
But you see, there's another aspect as well, and there's another aspect. Obviously, the natural disasters are different, right? But what do we do? I often say to people, think about life as a problem-solving puzzle. What do we teach in problem solving? We teach people, a few very basic things. And so, for example, one is to how to make a decision, and, how to solve a problem. But I think the overall message of the problem solving approach is that you don't solve one problem, you don't solve many problems together. You solve problems one by one, and you solve them in steps, and you start uh, with a smaller scale. So you see, that's these are very important things. In other words, I mean, even if you look at the way our education system works, right, we, as we grow older, the difficulties, the life becomes more and more difficult. Exams become more and more difficult, right?
Yeah.
And you see, so that's the whole kind of. So it's also about strategy. It's also about strategy. How strategically, uh, you know, or how strategic you are. So you don't have. So you. And as I said, natural disasters are excluded, right? We're talking about normal day-to-day kind of difficulties. So resilience is not like, you haven't done anything and you just go and want to do something. It doesn't work like that.
Yeah.
So resilience and self-efficacy doesn't mean that, you one day you decide that you are going to be the fastest pilot in the world, and you don't even know how to fly an airplane. It doesn't work like that, right? So we also need to keep in mind the gradual kind of or the stepwise approach that we learn in problem solving and in life.
Yeah, yeah, absolutely, absolutely. So once again, sounds like there are different important aspects or components. While we may not be able to directly, so to speak, build resiliency, but then through self-efficacy and through some specific skills building, by increasing the self-efficacy, then it can once again, when we go through hard times, which most people do in life, and that is when the resilience, so to speak, can be activated.
That's right.
Yeah,
That's
I'm
right.
also glad that you mentioned about early on, the movement of positive psychology, and I do want to clarify, or maybe to say that obviously the positive psychology does not associate with positive thinking. I think that is a very, very narrow sense of equating positive thinking to positive psychology, but certainly, in my previous podcast, we have talked quite a fair bit in terms of what is positive psychology and what is not positive psychology. So thank you for highlighting that. When it comes back
I'll watch that. I'll watch that.
Okay. That's right. When it comes to the stigma or discrimination around mental illness, I'm wondering what can we do to actually drive change to create a world where mental illness is seen in the same light as every other illness. In other words, to put toward a future where everyone believes that life is worth living, especially during this time where people are questioning about the meaning and purpose of their life.
I think, first of all, my views on stigma are slightly different from the mainstream thinking. Uh, and uh, uh, the second thing, I think the way stigma is seen in the West, uh, it's different in global south, and especially in Asian countries.
Yeah.
Give you an example. So there are many Asian countries in which people with mental health problems, not all, but some, like psychosis, actually are still in rural areas, can be considered to be God's friend or a saint, or that still happens a lot. uh, and uh, uh, and in many villages, remote areas in South Asia, for example, people with mental health problems, as I said, they call them friends of God, and um, and nobody will harm them, and they're just like um, not that people worship them or anything, no, but people have very soft kind of attitude towards them.
Yeah.
So, so that's what I mean. We need to have our own understanding of stigma uh, in Asian country, and I can talk more about Asian and South Asian countries rather than other cultures like the South Americans or the African. I don't know much about those in terms of stigma. Uh, so I think that's a very important thing. We should stop thinking about stigma in a very kind of as a universal concept. It's not a universal concept. It does vary. Second thing, I struggle with the concept of the interventions for stigma. People trying to fight through educational approaches, and yes, knowledge and awareness, these kind of things are very important, and they can play a huge role in combating stigma. However, that's not going to complete the picture. The picture, in my humble opinion, is that big part of stigma comes from the fact that mental health problems have poor prognosis.
Okay.
Right? And I can give you several examples. When people don't know what to do with this strange or bizarre behavior, they are scared. I mean, isn't it a fact that in the West, women with schizophrenia were being burned for centuries because they thought they are witches, right? That doesn't happen now because people know this is psychotic illness or neurotic illness, whatever, right? So I think that's another example I give you is of epilepsy. In many Asian countries and African countries, people thought that epilepsy is because of evil spirits. Okay, and you can Google and you'll find, the whole kind of all these stories of people thought that epilepsy is because of evil spirits or ghosts or this or that kind of thing. And then what happened? 20 years ago, 30 years ago, we had advances in treatment for epilepsy. So people had medication that could help them with epilepsy. And now epilepsy has excellent prognosis. And therefore, you will not see anyone who believes that, um, the mental illness, apologies, the epilepsy is because of spirits or ghosts. So it doesn't have that kind of stigma. So I think we really, until unless we improve the outcomes of mental health problems just through the campaigns and education, it's not going to be enough. It's important. I'm not denying that. But my point is that's not the complete picture. The bigger picture is educational part, awareness part, and then the prognosis part. We hardly, talk about the prognosis part in our stigma campaigns.
So when you talk about the prognosis part, like can you give me one or two examples in terms of what sort of campaign that can undertake to help the general public, especially once again, to reduce this stigma that's associated with the poor outcomes, so to speak. Yeah.
So no, so I'm not saying that you can. I mean, we can't lie to general public and say psychiatric problems have excellent prognosis. So I'm not saying about educating people and saying to them, oh no, they have great prognosis. They don't. My point is, we need to do more research on outcomes, on interventions for mental health problems, and when we reach a stage where we know, I mean, we still don't know, let's be honest about it, right? How much do we know how antidepressants work?
Yeah.
Right? How do antipsychotics work? Right? And how does even ECT work? We don't even know, or, you know, we don't know these kind of things. And I mean, I am a psychiatrist, so, you know, I'm not against medication. I prescribe every day. I prescribe ECT. So, but that's one thing. It doesn't mean that I should be, you know, I should give wrong messages to people and say we know 100% about antidepressants and antipsychotics and ECT. We have very good idea of how they might be working, right? But we don't know with 100% certainty. Like in case of diabetes, for example, we know what happens. In case of thyroid problem, we know, you know, what's going on. So I think, so my point is like improving the treatment for mental health problems is the way forward if we have to combat the stigma.
Okay, all right. In brief, I guess what I'm hearing from you is that again, a lot of times the stigma is associated with the unknown, like as you say, when it comes to the treatment outcomes of a lot of psychiatric illnesses. Yes, you might have some idea in terms of what might work, but still the exact mechanism at times can still be a little bit of a mysteries. And you know, when it comes to
that's true.
Yeah,
that's true. That's true. Because you see, the problem with the mysteries is people will actually try to find an explanation based on their framework, the mind framework, their theory of mind. So, for example, you know, if you say something bizarre to me, I might have different meaning, right?
yeah.
But if you say, for example, you know, so for example, you know, if you say you're God, right? Okay, I might take it in a different way. You might just, you know, but if you say this to someone in a religious country, for example, you'll be in trouble.
Yeah, blasphemy.
Right?
Yeah.
You blasphemy, absolutely,
Yeah.
right? So, and on the other hand, there might be culture where actually people will start worshiping you. No, seriously, you see what I mean? That is, so it's really anything that's out of ordinary, out of context, anything unusual, people will respond to that based on their theory of mind, you know, or whatever the belief system is.
Yeah, yeah. All right. And talking about belief systems, obviously is closely associated with CBT, the Cognitive Behaviour Therapy. I understand that early on, you know, you give us some examples, but for our listeners and viewers who are not familiar with CBT, can you briefly explain what is CBT and how can CBT help to promote mental health well-being in a diverse culture?
So, sorry, what is CBT and what's the second part?
And how can CBT help to promote mental health well-being within a diverse culture?
Right. So CBT is, in theory, is a very simple kind of idea. The idea is that it's not really what happens to you that makes you angry or distressed or depressed or anxious. It's not what happened. It's actually the way you look at it. It's your perception. And I know it's a common kind of thought or common sort of you know, perception that CBT started from the Greek. Not CBT didn't start, sorry, apologies. You know, the idea came from the Greeks, right? That, you know, Zeno who was a businessman, and he had a huge loss, and then he became a philosopher, and then we talk about the Romans, like Seneca and Marcus Aurelius, that kind of people, and they all realize that it's not what happens to a person, is what a person thinks about it that makes him depressed or anxious or stressed. But you see, what I always now correct this kind of this because I realize, because of my work in CBT and culture, that this whole idea of thoughts lead to emotions and not the events is actually very common in Asian and African countries. It's not a pure Greek thought. It actually, the thought so many other. For example, you'll find the same kind of thinking in Confucius's thinking. You'll find this in Jainism. You might have heard, and I always tell people the story of elephant and the six blind men, which actually, is all about perspectives. So the six blind men go to see an elephant. Everyone touches different part of the body, and then they say, okay, elephant is like a wall, elephant is like a rope, elephant is like this or that. And they kind of, because they are just fixed on one perspective. And this story is, you'll see, in African stories, in China, Japan, in India, they're everywhere. So this is one thing. People realized this thing long time ago, that it's not really what happens to me, is what I think about it. That is the kind of issue. Now, your second question is, the second part of your question is CBT in different cultures. Am I right?
Yeah. So to use CBT specifically to promote mental health well-being.
Yeah. So you see, there is a small kind of barrier. And the barrier is that the modern CBT was developed in North America, in US, and therefore it's basically, it's not the philosophy that there is any kind of, unique to the Western Eurocentric kind of thinking model. Is the way it is delivered and the way it was developed. And so that's why it needs some modifications if you want to use them with people from non-European, North American kind of backgrounds, or if you want to use them for people outside of Europe and North America. So you have to make some modifications. You have to make some adjustments so that they are more acceptable. And I can give you some example if you have time.
Yes, one or two would be great. It's always good to be able to illustrate through examples.
So, for example, the whole focus of CBT in the West is to help a person to be able to function independently, right? In fact, one of the dysfunctional beliefs in CBT theory is dependence on others. People from Asian and African cultures actually it's the opposite. So the belief that you are dependent on others is actually seen in a normal way. People are dependent on each other. Now, I have to say one thing as well, Edimus. People think that people in the West are independent, right? Individualism, all these kind of things we talk about, right? I do not believe that actually that's the case. And I believe that people in the West are also dependent. They're not dependent on families. They are dependent on systems. For example, what happens, if a grown-up man loses job, you go and talk to your brother or your, parents, if you can go back and live with them in many Asian African countries. What happens in the West, right? You lose your job, you ask the government to help you. You go on benefits.
Yeah.
And I'm sure, Australia possibly has the same kind of system like UK and US and Canada. So human beings are by definition dependent on something or others. So I do not agree with this whole idea that, okay, people in some cultures are less dependent than others. You are dependent on different things.
Yeah.
Right. So there are multiple kind of differences. There are many other differences, that we need to overcome before we actually use CBT across the cultures.
Yeah. Yeah.
But having said that, we have now so much evidence. There are dozens of RCTs from China, from India and Pakistan, and other countries in global south, which show that CBT is actually very useful in helping people with different kind of problems. We have used in primary care, we have used in our trials, we've used in secondary care, we've used for depression, anxiety, schizophrenia. We used for everything, and even in UK and even now in Canada, we use, and there are other colleagues, the people who actually have used CBT for diverse population, and it does work. You need to make some adjustments, but yeah, it does work, and it's very effective.
And sometimes, as I said, there's a lot of evidence to support that CBT works. But as you said, sometimes we need to know how it is developed and delivered so that it can be culturally and perhaps also contextually appropriate as well.
That's right. That's very true, and that's the case. And when I started my work in CBT, cultural adaptation of CBT, I tried to give a definition of cultural adaptation, which was a little bit more kind of complex. But now I'm kind of realizing, and my current definition of CBT and cultural adaptation is very simple. And it is that, when you and your client are of different therapeutic, different background, whatever the difference might be, okay, whatever you do to make sure that you can engage that client is called cultural adaptation. So in other words, cultural adaptation is all about engaging the other person, because cultural adaptation doesn't mean you change the theory of CBT.
So in other terms, when I hear about the word engaging, I think that in the counseling setting, sometimes we also use to be with saying that developing a positive therapeutic alliance with your client, basically again in sync. Okay, so the true engagement, you build trust, you trust that obviously a lot of doors.
Because you see, the concepts of CBT are universal, right? So the basic concepts are universal, So now just the kind of issue is just like how you deliver those concepts, how you use those techniques.
Yeah. And I know that you spend a lot of time, obviously, to develop these cognitive behavior therapy programs called eGuru. And again, for our listeners and viewers out there, if you want to dive deeper in terms of how you can actually use CBT in terms of promoting the mental health well-being, then certainly you can check out the eGuru, which I believe there is a series of videos, psychoeducational videos and skill-building exercises. Is that right?
So I realized a few years ago, the only way the only way, and I sincerely believe in that, and normally I don't exaggerate, so so I'm not exaggerating. I do believe the way forward, is to reduce the mental health gap in global south, global north, everywhere. The only way we can do it is through use of technology. Simple as that. You see, there are problems. So yeah, so I did e-guru is one example. Then we actually I have developed quite a few self-help manuals that we have tested. One of them we actually uh, uh, we use that to to develop a self-help website. We tested that in Pakistan, and uh, so it's an online version. It's a website, interactive website, and uh, uh, then there are other programs as a part of a team working on these different kind of initiatives. Anyway, so I do believe that that's the kind of way forward. Two main things I see that can change the mental health or the future of the mental health. And I'm being very specific. I'm not giving you a vague kind of generalized statement, like, okay, technology can change the mental health. Yeah, man, we all know that. I think the two kind of specifics. One, apps on your smartphone or on your web or wherever. So number one are apps which help you screen mental health problems. Screening apps,
Okay.
they have a huge potential. And number two are intervention apps, which can use like CBT and that kind of stuff. So I think these are the two areas. Unfortunately, there are millions of apps. I'm sure you know that. But I don't see any kind of progress in these two areas, uh, and especially evidence. There is such lack of evidence in this area. But you see, there's another problem that comes even before. Let's suppose we have an ideal, we have a great mental health app for screening. Okay, the ideal one. So my ideal screening app is the one that is, so good in screening with a very high level of sensitivity, specificity, and all kind of stuff that actually can diagnose uh, mental health problems. Okay, we are far from that. But and the second one, let's say we have an app that can deliver psychotherapy. The problem is this. The problem is we do not have um, uh, uh, we don't have many people in this world with high level of digital literacy, right?
Yeah.
Now, I see all these, I see so many people, okay, and I talk to my colleagues, oh, we are conducting a trial of an app in a small village in somewhere, Africa or Asia. And I said, okay, that's great, and what's going to happen after you completed the trial, right? Because if people don't have access to technology, people don't have digital literacy, how is that going to change anything? So I think here in this case, we are in a race, but we are not. Many people don't realize. Maybe because many researchers, are like quite old like me. They don't understand the very basics, and the basics are that you need to educate people in digital literacy and how to use an app. Number one. Number two, give them a smartphone. Number three, they need and they need internet. If you look at the digital readiness index, I don't know where Australia is, but Canada is number 17 in digital literacy index. And apart from Singapore in top 20, you will not see any non global north country.
Wow. So this is almost like a foundations. It has to be built.
Exactly. Yeah. I mean, I mean, even Canada, right? For example, in Canada, for example, and I think Canada is actually very much is similar, at least in terms of geography and population distribution to Australia, right? Uh, and so apart from the bigger cities, people live in small, very tiny little towns. Okay, they don't have access to technology. They don't have access to internet, high-speed internet. You need these two things before you can use the potential, you can exploit the potential or the power of the digital mental health.
Absolutely, absolutely. Wow. Well, Farooq, thank you for such a insightful discussion and sharing of yours. I had just one last question for you. More on a personal level, obviously, as a psychiatrist, as well as someone who has been in the mental health area for so many years. What is one thing that you have been doing this week to look after your own well-being?
What is one thing what?
That you have been doing this week to look after your well-being?
You see, the kind of problem is, I am terrible looking after my well-being.
Oh,
I but I have a routine in that, and it's actually before I'll be quite honest and open with you. So I was diagnosed with diabetes 4 or 5 years ago, and actually that changed uh, my routines a lot. So for the first time in my life, I started sleeping for 8 hours. Uh, I started having my breakfast and generally being careful about food. And here we have this one. This is a long weekend, so we're planning to hopefully go for a long walk some stage.
So what you're talking here again is what we sometimes term as a common sense lifestyle changes, where a lot of people know about it. It's just having the motivations and making the intention effort to do it in terms of sleep, diet, movement, exercise, connection with other people, nature, and even this whole sense of meaning and purpose.
Absolutely. I think that these are very important things. And I think one aspect that I would emphasize uh, is to always keep in mind that, we need to look after our minds and bodies both at the same
time. Yeah,
time.
absolutely. Yeah, because they are not like compartmentalized. The two is all together.
That's the problem.
Yeah.
I see.
Well, that's all the time that we have for today. Once again, thank you for joining us, Farooq. And if you want to engage Farooq's expertise in mental health and CBT training, I'm sure that you can contact him via his LinkedIn profile. Thank you for watching. I'm Adimas from Strong Optimizers. We're here to bring out the best in you by optimizing your strengths. Have a fabulous day, everyone. Goodbye.
Thank you. Bye-bye.